I'm Darlene Hutton with QRS Educational Services. The video today is called Preparing for Intubation. And this is a video that has been put together specifically for nurses who may be in a position that they will be asked to assist with intubating the patient. When doing so, remember the term slope. Each of these letters will be found either in the patient's room or in the crash cart, specifically in the airway section. There are 5 S's. We have our syringe, our stylet, our stethoscope, sedation, and suction. There are 2 L's, lubricant, which is your water-soluble lubricant, and your laryngoscope. One of the things that I find causes some concern for practitioners using a laryngoscope is they're not really sure how to take the blade off and on with the least amount of challenge. And the secret in taking off the blade is make sure that the blade is bent and the hand that is holding the handle, that thumb is going to be pushing the blade off. This other hand is really just helping to guide the blade. So you would find your appropriate blade, and the secret in putting the new blade back on is to ensure that the blade is bent. When you lift up the blade, you want to ensure that there is good light source. If not, you can replace the 2 AA batteries located in the handle. There are we're on the O part of slope, and that's the oxygen. You want to make sure that you've got your oxygen supply, and that'll be delivered via your ambu bag. There are 3 P's: patient, position, and pressure. In terms of the patient, when we are looking at an oral airway, people often question whether we leave the dentures in or take them out. And the general guideline is leave the dentures in if they are sealed well and fitting well in the mouth, because it does help to provide a good seal. When we are putting in an advanced airway though, any removable implant or dentures that are in that patient's mouth do need to come out. So that's what we would call for patient. There are a few things in terms of the position of the patient. Number 1 is we do want to promote the head tilt chin lift. And one way we can do this is by putting either a roll or a towel underneath the patient's shoulder. One other component of the position is the level of the bed. If you are asked to raise the bed, you're really wanting to look at about the xiphoid process of the person intubating. Raise the bed to that level. It really facilitates ergonomically the skill of intubating for that person. The last P is the application of pressure. The guidelines indicate that we do not routinely apply cricoid pressure. However, there may be circumstances where we are asked to apply pressure. Okay, so if you need to apply cricoid pressure, you're going to feel the most bony prominence, which is your cricoid cartilage. Just underneath that is your cricoid ring. You only do this to a person who has no gag reflex. And with your thumb and your index finger, you're pushing straight down. What this does is it obliterates the esophagus. Some people feel that it might actually facilitate in viewing the vocal cords. So that's one way pressure can be applied. A second way that pressure can be applied is called the burping technique. It stands for back, up, right pressure. And really in this position, what we as the facilitator for intubation are trying to accomplish is manipulating the cricoid so that the person intubating can view the vocal cords. So oftentimes the person who will be intubating will take your hand and manipulate it over the person's cricoid. Either way, when pressure is applied, you need to maintain that pressure until the endotracheal tube is inserted, cuff is inflated, and verification of placement has been ascertained. So those are the 3 P's. The final letter is E. There are 2 E's. We look at the endotracheal tube, and for an adult, we usually go with a 7.5 to 8.5 size. We need to ensure that the cuff is inflated with no leaks. And you can leave the syringe attached if you'd like. And the second part of the E is your end tidal CO2. The current guidelines recommend that the best way to run a code with an advanced airway and the best way to monitor the endotracheal tube placement is by continual waveform capnography. In our practice throughout the province of Ontario, we have found that the majority of hospitals do not have all of their crash carts equipped with continuous waveform capnography. So the next best thing would be to use your temporary end tidal CO2. When we open the package and we take out the detector, the inside of the detector, this litmus paper, is usually a purple color. When we have the endotracheal tube in the patient, and this is attached to the end of the endotracheal tube, which we will show in our next video, and you do your 5-point check, listening over the stomach, the anterior lung fields, and the lateral lung fields. If you are in the correct placement, what will happen is the patient will be exhaling CO2. The CO2 will react with this purple color initially, and it turns it into yellow. And yellow tells us, yes, we're in the right spot. We would then confirm placement of the endotracheal tube by doing a chest x-ray, and hopefully we'd also see that the oxygen saturation has improved. So that is the acronym SLOPE.